So it's my pleasure to introduce Professor Chris Edwards, who is a professor of rheumatology at the University of Southampton in UK. He's the chair-elect of the ELAC Standing Committee for Education and Training. He has been involved in the development of recommendations in the rheumatology world, and we are really looking forward learning from his experience. Thank you very much.
Okay, so thank you very much. Thank you for the kind introduction. And thank you for allowing me into your group. And from the moment I started thinking about this work and thinking about the presentation, then I start to notice achondroplasia more and to try and learn a little bit about it. So it's very interesting for me to hear the discussions you're having. But I think there are some common approaches for all clinical specialities and all groups when it comes to thinking about recommendations and guidelines. And hopefully I'll be able to go through some of those. And I was interested to hear Melita's presentation, and I was just thinking about how you might simplify recommendations from how you divide up the stages at which you might want to care for someone with achondroplasia, whether that's on clinical activity, what we do, diagnosis, monitoring or complications, or whether that's through the life course approach where you look at early life and transition and middle life and later life. And the other thing, just hearing about the differences between countries and even the desire, which is certainly there in rheumatology, to try and unify guidelines across the whole world so everything's the same, that actually a little bit of tension between different organizations producing guidelines is sometimes a good thing, I think, because sometimes it leads us to really question what those differences are. And the key is just to be very transparent about what those differences are and to show where people agree and where people don't agree. Okay, so here are some disclosures for me. And then, now your view on recommendations depends a bit, I think, sometimes on your personality type. Some people really don't like recommendations. They think they're a straitjacket that confines their clinical approach, and they stop them giving this individualized approach to a patient. So are you a pessimist in this regard? Or are you an optimist who believes that recommendations are fantastic things and are seen as a unifying force, something that brings us all together? Well, certainly getting together and discussing and describing is something that improves the quality of what we do, sharing other ideas. And I think recommendations are a really fantastic way of bringing us together. The process itself, whatever the outcome of the recommendations, educates us as well. So whatever comes out of a recommendation meeting, we're always educated by this process. So just imagine, are you the pessimist or are you the optimist? Maybe we'll discover when we have the discussions. So at their simplest forms, what are recommendations for, and do they make any difference? It's a way, of course, of trying to get the best evidence possible translated into a usable form to care for our patients. Melita already mentioned the fact that there's not always the evidence there, and so they're also emerging sometimes of a systematic literature review and the evidence that exists with clinical experience. And I think that's okay, as long as we define the areas where we know we don't understand, and that becomes our research agenda at the end of the process. Then I think knowing where we know things and knowing where we think things is important, but the merging of clinical experience and evidence is something that comes into recommendations and guidelines. It helps us to increase the speed of the uptake of new advances in therapies and allows us to try and be consistent across our approaches, although there can be some difference because there will be some unique circumstances within populations, within environments, within our healthcare systems, which means there needs to be some flexibility in any recommendations that we produce. It, of course, allows us to have a standard to say, this is what we're doing, this is the standard we set, and then you can audit against that. And sometimes that's a useful force to change things with the people who pay, with politicians, with society in general, to say we're not fulfilling this against a national or international standard is important. And that, of course, then influences our ability to receive economic funds, which allow us to look after our patients as well as possible. And I mentioned already that education is always there throughout the process, but the other reason for trying to produce recommendations is because then a group, hopefully of experts, gets together and spends a lot of time thinking against the evidence. And they're doing that partly to help the rest of the community and to reduce the amount of information that they have to take up to make those decisions. Now, this little circle here, starting at the top, defining the problem, is just drawn out from some of the recommendations that I've been lucky to take part in the past. And this at the bottom is the reference for an SOP that's used by EULAR, the European Rheumatology Association, to define how it produces recommendations. And there are clearly these stages. So if we were producing recommendations to care for patients with rheumatoid arthritis, for example, we'd define the problem. You've done this. We'd assemble a task force. You've done this already. You might produce a systematic literature review to look at what evidence exists. And then you develop the recommendations, which really come in two parts. There are overarching principles, those things that we think are so vital that we could agree to these across the whole of the care we deliver. And then there can be more specific recommendations. But then you have to try and complete the circle. The recommendations on their own are not much use unless you disseminate them in some way. And we'll come back to how you may do this. And then you come back maybe to going round the loop again and again and again with different iterations of the guidelines at different times. Now, this is a little bit of rheumatology data, but the subject matter doesn't matter. It's some work I've been involved with, because some people will say, can you prove that recommendations make any difference? And here are a couple of pieces of work using interrupted time series. So this is, high statistics. And on the left-hand side, this is about a British guideline that was brought in to tell us how to better treat patients with rheumatoid. And I hope you can see the deflection in the line going upwards with a greater uptake of the use of a drug appropriately, methotrexate in this case, after the British Society of Rheumatology produced its guidelines. And then on the right-hand side, you can see once again within the UK from a big data set, the reduction in total knee replacements that started to occur for patients with rheumatoid arthritis after we were allowed to, through guidance, use one of the advanced therapies, one of the biological therapies, anti-TNF therapies. And so there are various bits of evidence around the world in different disease areas that allow you to justify that when you make a recommendation, you can change practice in individual countries, and you can demonstrate this with data and statistically. Okay, now I've already mentioned, so various organizations have ways of doing this, and different medical bodies around the world will use different approaches, Delphi type approaches, and actually the EULAR guidance on producing guidelines is based on a modified Delphi process to try and simplify this. But what's very important is it introduces a voting process. And that voting, of course, is important for a number of reasons, and we'll come back to that in a moment. But the main thing is to try and get the group view. It's to try and make this as democratic as possible so that there is robust discussion and then people vote. And when they vote, they then vote on whether they agree, and after that they vote on how much they agree with a particular recommendation, and that's recorded and that's presented so everybody knows how much agreement there is. It's a very honest and transparent way of doing this, which keeps everybody happy. So overarching principles are the bit that we're going to think about at the moment, and if we just think about what they might do, and just some things, and there's some other bits I was going to mention as well. You know all of this, you're all experts in your field, so forgive me if any of this is teaching you things that you already know, but keeping focused on what you're trying to achieve, the overarching aim, is very, very important. We all have our subspeciality interests, the particular thing that really bothers us, that we really think is the most important, and it's trying to think about what the overall task is. Keeping things as simple as possible. It's very common to try and make a piece of guidance or a recommendation longer and longer and longer and longer with as many sub-clauses as possible, so that each principle becomes 5 different principles within a very, very long sentence. So keep it simple. It needs to make sense to a non-expert, because one of the reasons for having this sort of information is so it's accessible to as many people as possible, and that people outside of your speciality will understand it, because that's very important when you try to influence and you try to get resource and uptake of the sort of guidelines and principles that you introduce. and therefore simple language is important. And this is just one thing, and I don't know whether this would chime with you as well, but one of the things that I've spent a lot of time over the years doing is understanding that many guidelines like this are produced in English, and English is not the first language of most people who produce guidelines. And so we all have very slightly different translations of what a word means, and they can be very strict in particular languages versus others. I have spent hours arguing with people about a particular recommendation, or the group is arguing, and then when we get to the end, we realize it's a different understanding of the same word. So right at the beginning, if there's any dispute, I would always think, do we mean the same thing? And sometimes that means we've produced glossaries of exactly what we mean by particular words. Maybe that's obvious, but it saves a lot of time if you think about it. And also thinking about how you write it in very generic scientific English, but what I would call European English. You want to reflect the strength of all views in the group. Of course, that's why you vote. And try to not have too many of these recommendations. Okay, so here's how EULAR recommendations used to be produced. A bunch of men sitting around a table and just guessing, I think it should be this on the basis of my opinion. And the quality of those, as a reference at the bottom from one of my fellows who in her thesis did a piece of work looking at the quality of recommendations and just thinking how we improve them. Some of the things that we now do better is to include patient groups within this. This may not be for now in this particular group, but in the future, sometimes that can improve the quality, the relevance of the recommendations that are produced. Now, these are the last iteration of the recommendations from EULAR for treating rheumatoid arthritis. And the subject matter just doesn't matter. This won't be of interest to you. But I think the broad ideas of these overarching principles are. So the first thing is a very simple statement. And you could imagine substituting achondroplasia for some of the words where we have rheumatoid arthritis. So treatment of patients should aim at best care and is based on shared decisions between patients and their specialists, for example. Now, it doesn't have to be these words, but there is a principle about it sharing between patients and doctors. There is something about taking into account disease activity, comorbidities, and treatment. There's a question that clearly this will be different here because this is about treating with a number of different specialists who have expertise rather than it's easier for us perhaps thinking about rheumatoid. We would very much want to stamp a rheumatologist on this, but it's thinking about who does this. It's how you might need to change treatment throughout life. And then the last one is the importance of this to society, that this is an important disease and that it's important that the best possible care is given to people for society, for the medical service and the individuals. So you can see the sort of principles. The other thing, and I mentioned this right at the beginning, is just to think how you divide things up into phases. And actually, Melita's talk did this already. And whether this was, I think on one of the slides, it said clinical activity around diagnosis, monitoring, complications. So you could think like that. Or over the life course, very early transition, later life, for example, reproduction thrown there in the middle. So you could divide it up in different ways. And by dividing it, we simplify it. And then this is a little bit about the voting. So this is voting from some of the recommendations that I've been involved with. So the picture of you sitting around the table at those meetings in Berlin looks a very similar sort of process. But it's thinking about how you do it. Now, the way we've done it for recommendations, usually with EULAR, is that you have a proposed recommendation written out or principle. The group votes. If the group votes with more than 70% agreement, 75% agreement, more than 3/4, it's carried, that's it. And then you have a second vote on how much you agree with this out of 10. So you get a feeling for, was this controversial or was this very straightforward? If in the first vote, 75% don't agree, you have a talk, you have a discussion, you have a redrafting of the principle, and then you vote again. If it's 2/3, if it's 66%, then it's carried. If it isn't, you discuss again, you redraft. And the experience of this is usually for the first one or two, it can be quite tense. There's a need to have some blood on the floor almost and to have a robust discussion. And then over time, perhaps it becomes easier and easier to think through the process. But robust discussion is good. That's what you need. And keeping a record of this and keeping it for part of the publication is important. Okay, so then how might you disseminate this? No point doing it unless people know about it. And this can be done in different ways. So educational events to roll out, to demonstrate what these recommendations are locally, nationally, internationally. Preceptorships where you allow people to go and train or spend time learning in different departments to share best practice and to publish. You've already have that aspiration to publish your output. So I think that's fantastic. Questionnaires of the greater community, because then you involve more people, and then the process of other people filling in the questionnaire, they have to think about the recommendations in more detail. And one of the things the European organization does is it stamps centers of excellence. It says to be a center of excellence, you need this, and it's a robust peer review process. And as a result, you get a plaque. And those things can seem silly sometimes, but I think they're important markers that help all of us as we're trying to improve care. And then recommendations allow us to get information to politicians and to the media to change policy. Okay, so here's the sort of survey or questionnaire you might have. So a recommendation number 1, 2, 3, 4, 5 on the left. Level of agreement, did you agree 0 to 10? Will you apply it in your everyday practice? And then on the right side, will it change your clinical practice? And that's the sort of questionnaire that can be given over to a much wider community than the group you now are today. And here's an example of one of these from a recommendation process that I was involved in the past. So you can see if you look at the table at the bottom, it just here's recommendation 1, here's the text of the recommendation. And you can see from a large number of people, this was sent out to 2,200 rheumatologists, and the agreement, the mean level of agreement was 8.2 out of 10. People would apply it in 80.7% of the cases for the first recommendation, and it would change their practice in 99% of people. So, excuse me, in 99, which is 28% of people, forgive me. And so you can just see, so that's very simple, but it gets a lot of attention. It's another publication and it helps to complete the circle. And thinking of circles, here's the circle, because once you've gone round it once, you have to define how many times are we going to do this. The first one is never going to be perfect. You do it again 3 years later or 5 years later, and there's more evidence and there's more knowledge, and that helps you to do a better and better job and to produce better and better recommendations which improve care. Okay, so that's all I wanted to say about recommendations. That's a rheumatologist's view. I hope it's useful to think about it. And just those key bits of, I think, of keeping it as simple as possible, having some sort of voting process so everyone's view is taken into account. And that little bit about just the language bit, it may sound trivial, but I think when many of us are using English as a second language, then I think that's very important that we're using the words in the same way. So thank you very much.
Thank you very much for sharing your experience. It was really, really interesting and quite important for us. Are there any questions or comments? So I have one question. How do you manage differences between countries? You are going to choose very simple recommendation, but still we have differences between countries and it will be difficult to share that.
Yeah, I think it depends what you're trying to achieve. You can do it in a couple of different ways. For me, I think what that means is you have to pick the imperfect fact that you have to have fairly generic comments which are applicable across countries. That means you may not have incredible detail in them.
Yes.
They may be much more generic comments. We always want to have all of the detail within it, but if you want it to be international, I think often it can't be as detailed as that, which for some can be frustrating. In one of the processes I was involved in, we had an international approach, and that was very generic, but then we ran the same process in individual countries where people could alter it and they could change that. Now you may not want to do that because that can complicate things in other ways, but you can try and develop, to adapt that. But I think it just means that you have to have overarching things and think what a success it would be to have overarching guiding principles that talked about best care and just highlighted the importance of achondroplasia, which allowed you to wave the flag for your patients, which is so important. I don't know if that answers that. Yes,
so you have to be very simple and not too precise.
That would be my approach from the things that we've done, yeah.
And I have another question about language. So you are completely right, words are quite important. And have you think to translate recommendations in native language?
Yeah, they haven't been generally. So the EULAR recommendations are all produced in English, and that is their official published form. But we just try very hard to keep the English as European as possible. Yeah, there are words and phrases I might use as a native English speaker that I would avoid when I'm trying to produce these sort of guidelines. I think it gets it even more difficult when you translate them, because then it really then starts to mean different things in different places. Yeah.
Completely. Thank you very much. Any other questions? Thank you very much.
I have a question to Edward. Thank you very much. I mean, in the area of pediatric endocrinology, the level of validation of recommendation is very low. I wanted to ask you if you came across some studies showing what is the level of validation in the recommendations in general, because this could be very important to know how to overcome the barriers of these limitations.
So when you say validation, I'm not sure I completely understand what you... So do you mean after the event of doing it, has it been validated and shown to change practice? Is that what you mean?
The real world, right.
Yeah. Yeah, so I don't know outside my speciality area. I can demonstrate those slides I showed you about rheumatology practice shows now you can criticize the approach and the statistics, but as far as I understand, though the sorts of approaches that we use, like these interrupted time series, demonstrate for recommendations, certainly within rheumatology, that practice has changed around the time that guidelines change. Now, whether that's attributed exactly to the guideline changing or whether it was a change in practice that also leads to a change in the guidelines, who knows? But you can demonstrate stuff that which will show some of what you're asking, I think.
When you have this circle, so after 3 or 5 years you repeat the same, but then these are not the same group, but people from the same expert centers or something like this. I think, are there any quality assurance, like a registry where they compare the data from different of the participating centers? Or because in your case you you show the I think the insurance data or surgical data of knee operation.
Yes. Yeah.
And this is some I think very good item which you can control for. But for example, in our case, I think if you want to say, for example, the foramen magnum stenosis surgery, is it necessary in 2% or in 40% or so? Then it would be good to really document and say, okay, after 5 years, we have a different number, and how it changes the outcome or whatever you control. Is this a common practice, or is it more optimistic and you never will get such a...
Well, I think you can measure it in a couple of different ways. So I think you can ask simple questionnaires. You can audit whether people are fulfilling the recommendations you've made. You can go to centres or to a whole nation, the specialists who look after the patients, and say what percentage of people are operating to these standards. Of course, you never know for certain. The other part of it, showing that care is different or different approaches produce different outcomes. I think that's the research agenda, probably. And I think recommendations should always have a section that say the research agenda, the things we don't know are these. We encourage studies in this area. And hopefully by fulfilling that requirement for studies, then you change the evidence base, which changes the guideline the next time you think about it.
Yes, of course. But I think in rheumatology, you don't have such a system, or...
A system to measure exactly. There are registries for different, but they'll be different. So we have registries of biological therapy use. So having registries allows you to record what happens to be. And I think registries have a power which is part of, but separate to the recommendation. So for rheumatology, they're not linked, but one feeds into the other, in that the registry data becomes part of the evidence base that informs the guideline.
Thanks. Thank you.
Melita, I can see your hand up.
Yes, Melita.
Thank you very much. That was a great talk, Chris. Thanks, very motivating. So yes, the graph that you showed did show an uptick when the guidelines were published. And so my question is around rubber stamping. So it's the backing that you get for your guidelines that might be useful in that respect to make them successful and adopted. Is that right?
Yes, so rubber stamping by so do you mean rubber stamping by different organisations? So there's the trying to prove it makes a difference. To be honest, I don't think there's lots of data on that. People perceive it to be a good thing, but I think rubber stamping from organisations and having buy-in from other colleagues is important to this. But, you know, demonstrating how much good they do is quite difficult. You know, we believe that if we get together and we talk and we discuss and we try to synthesize best practice, that must produce good. And I believe that. But actually proving it, I showed you those examples, but it is quite difficult to actually prove that outcomes change after you introduce recommendations.
Yeah, okay. Thank you. Thanks.
May I speak? Have a question, because in a meeting we have with BioMarine around about limb lengthening, we realized a completely different approach from the north part of Europe to the south part. And this is probably due to a different psychological approach, not only from a scientific approach to this problem. So how can you manage this different, not really scientific, but more psychological factor in a guideline?
Okay, I think that's an excellent question. I think that's worth talking about. I think what it would make me do is to try and look for the overarching principles that are not controversial. So things like saying that a specialist with experience in the care of a disease should be responsible for their care, or that it should be a shared decision with the patient. These would be common approaches across all countries. And I think you have to inevitably leave some room within a guideline to allow all countries to feel comfortable, because otherwise we alienate colleagues and we try to choose which is best. And it's none of us will know which is best in this situation. All approaches will have their merit. And so I would always try and be as general as possible, as overarching as possible in the principles, and maybe leave that detail for another time.
Okay, thank you. So we have room for different countries.
Yeah, well, personally, I think there has to be, because that's the only way we can have international collaboration and we learn to work together and trust each other. So we have to do that, and then over time, and of course, when you introduce a recommendation, sometimes if it's controversial, the last thing you want to do is alienate a group of colleagues.
Okay, I think we can get the next sign.
Can I just add a word, Professor Klaus?
Yeah.
So I think this is great. I mean, the discussion is really good. One of the things that we found useful is also, and I think along the line, what Christopher has mentioned, not to alienate other groups, is to be conscious about the different resources available in different countries. So we may go on recommending MRIs, but there are places that could only do plain X-rays and they just don't have access to MRIs and CT scans. So keeping it broad, keeping other options, available for colleagues across the globe that may not have the same resources, I think is very important when we put these guidelines together. Yeah, especially when the evidence is really, very low, as you know, most of the things that we have talked about, and Melita has rightly pointed, there's really not solid evidence about most of the things that we are going to discuss with regards to achondroplasia.
Yeah, I think this is a very important question and statement. And I think during my whole medical career, I'm always heard about new developments, and everyone wants this. And then after 10 or 15 years, we see this is not so important. But actually, the countries where treatment or diagnosis is not available, I think this is important to say. We should not go first for any new tool if it's not proved. Yeah. Okay. Thank you for this statement, and I think I will now change. Oh, yeah. Now, okay. These are my disclosures, and before we had this first meeting, and where we discussed about the guiding principles, and we put them together, and there were now 6 guiding principles for the management of achondroplasia. So we really take the recommendation from Chris to say keep it simple. Yeah, as I think in the group already we are agreed that we want to develop guiding principle for achondroplasia to coordinate the consistent care for people with achondroplasia, because whenever a child with achondroplasia or adult with achondroplasia comes to one of our centers, they should see what is the necessary tool and for diagnosis and treatment. And I think we all agree that we want to improve the outcome, not only in one special field, for example, in the height or so, but in all kinds of complications like ear problems or so on. And for this, we want to provide for our patients multidisciplinary team management of achondroplasia. I think this is what we can offer to our patients at the university levels, but sometimes it's not possible in all centers. But these are the goal, what we are thinking. And also, we should also provide a foundation from which to investigate individual aspects of care. And this is also what already mentioned, that some countries have different tools than others. As Chris already said, we will have this voting, and the principles are whenever we have a 75% agreement, then we can then we say, okay, there is an agreement. And the second part that everybody has to vote for is the level of agreement with each of these principles. And we will have one page where we give this recommendation and we have this discussion. And so you can vote with yes or no. And if this, as already said, we have this agreement of 75%, which means strongly agree, which means we have a consent for this. We also can have on a scale what I already said. And if this agreement is not achieved, we will vote again. We will discuss we will redefine the wording, and then we will vote again. And only for you, the results will be anonymized, so everybody can really take what he really believes and not what he should believe, I would say. Mean values on the level of agreement will be shared on the system links and will be then included in the publication. So these are the 6 guiding principles. So we will discuss about the first statement: achondroplasia is a lifelong condition requiring lifelong management by an experienced multidisciplinary team led by physicians, clinicians experienced in achondroplasia management. Close monitoring during the first 2 years of life is critical. The second principle would be, when a diagnosis of achondroplasia is made or suspected in utero or after birth, the family should immediately be referred to a physician experienced in achondroplasia to discuss the prognosis and management of the condition. The third one is, decision-making should be shared between the person with achondroplasia and or the family and the multidisciplinary team. Fourth, the primary goals of management are to enable early identification and treatment of emergent problems, provide education, and support to encourage a healthy lifestyle, positive self-esteem and mental health, and to encourage independence. And fifth, patients should have access to a variety of adaptive measures, support to ensure proper usage, and priority access to new medications as they become available. And lastly, regular monitoring in adolescent and adulthood should continue under an MDT and lead physician with expertise in achondroplasia management. Care should include genetic counseling and management of pregnancy. Okay, then coming to the first guideline. So we will discuss this first. Achondroplasia is a lifelong condition requiring lifelong management by an experienced MDT led by physicians experienced in achondroplasia, and a close monitoring during the first 2 years of life is critical. And to this statement, there is first the statement: most people with achondroplasia have a normal or near normal life expectancy. Yeah, I think we can start with a discussion with this first sentence. Most people with achondroplasia have a normal or near normal life expectancy. Are you agree with this?
Yes.
Or is there any discussion?
Those awesome data showing that the mortality in terms of cardiac failure is 10 times higher. So I wonder that this paper could be taken into consideration, or what about this? I mean, how can say it's normal life expectancy if you have 10 times more mortality in terms of cardiac function?
Mm-hmm. Maybe someone else will comment on this.
May I make a quick comment? I think this is, in my opinion, I agree with this. The exception would be the first 4 or 5 years of life. I think after, if they are okay until 5 years of age, they don't have cardiac issues and other issues, then I think the life expectancy is near normal. So I think the critical period is the first 5 years. If they don't have major issues, then I think mostly they would have normal or near normal life expectancy.
Especially to the cardiac problems, we had in one of our annual meetings, or not one, and 2 or 3, we had a cardiological examination, including ultrasound in around 200 achondroplastic individuals, and there were no significant sign of cardiovascular problems, but I know these are not published yet, but I will already mention this.
I know that Julie Hoover-Fong's data shows that life expectancy is reduced by 10 years across in general, without sort of picking out why that is, but just as a general observation.
You mean from the Pauli, or there was one paper, yeah?
No, Julie Hoover-Fong's.
Julie, yeah. Yeah, but the experience, this is this your experience too, or we have no data, or?
Life expectancy, full stop. But it sounds like it is. I mean, based on the data that we have, it is reduced.
Okay, so Chris recommended that we we will have to go to the overall principle, but otherwise we will not end up today.
I'm in agreement with your statement for sure.
Yeah.
Okay. Klaus, it's Martin. Yeah, I think in the time today, I think we probably can vote on the principles. If they don't get agreed with, we can spend more time. I think when we go to a manuscript, there'll be plenty of time to look at those individual references, and I'm sure everybody here will share the additional ones. If you're happy, Klaus, to move on to just vote on the principle at the top, if people are happy with that, does that make sense to you?
Okay, should I read
so
this?
Callum, you can, if you read out the top principle, Callum, can you put up the poll?
Okay. Okay.
So once you just click and submit. Callum, let me know when you have 10 votes in. Or 11 votes in, I think, is it? I can't remember how many votes should we have? Katie?
We should have 14.
14 votes. So there's some people not on camera.
Oh, although I think Dr. Barrow is going to have to leave us in a minute, so we may have 14 for this vote and 13 for subsequent.
Okay, Callum, how many votes have we had?
We've had 10 so far.
Anybody not voted?
I cannot see where I can vote, actually.
It should have popped up in front of you on the poll. Normally when you're on Zoom, it should have popped. If you perhaps tab between.
I see the raised hand, yes and no. So
no, it should pop up on the middle of your screen. So if you haven't got that, Professor Mortier, are you happy to declare your answer publicly, and then we can make sure you get it next time, or do you want us to relaunch?
No, I do agree. Yeah.
Okay. Okay, Callum, let's go to the result then.
Okay.
We have 91 and 9.
Great.
So, Klaus, I think that's
yeah, that's great. Well over 75.
I just want to say you're all much nicer than rheumatologists, because normally there's bloodshed at this moment. So I'm changing speciality. I'm coming to your world.
So settle it down then, Callum. I think we will discuss the other bits as we go forward. So at this stage, let's just look at level of agreement. Yeah. Callum, can you pull that up? So hopefully, Gert, you'll see a pop-up in the middle of your screen, on your Zoom screen.
Okay, there was.
So this is again a 1 to 10. Can you see that, Gert, or Professor Motier?
No, I don't see it. It seems
on your main Zoom so do you have your Zoom as the slide as a complete screen?
Yes, I do see the slides as a full screen. I see you're viewing Sarah's screen. I see.
It should be honestly. If you just
but I don't see the full.
To say because it.
Maybe Gert, you can vote with your chat.
I can do that. Yes.
Yeah.
If you send a note to Callum. Again, for this one, we don't need to get everything today. We can come back to you afterwards. So if we have, how many votes do we have, Callum?
We have 11.
Okay, so Gert, if you send a chat note to Callum, then he'll collect, or to Kate. They will.
I'm happy to share it with everyone. I put it in the chat box now.
This is just you have to. On this one, you have to answer of 1 to 10.
Yeah.
Okay. So how strongly do you agree with this principle? 1, not at all. Up to 10, strongly agree. Strongly agree from Chris. These are very, very, very good. Okay, Callum, let's move on then. So, Klaus, let's move on to principle 2, and again we can talk through that a little bit now. So, come to that down. Oh, Callum, no, come! Don't show the results of this one, Callum. Let's
okay.
Because we have to get Gert's answer in if it's different. Okay.
Okay. The next question is when a diagnosis of achondroplasia is made or suspected, either in utero or after birth, the family should immediately be referred to a physician experienced in achondroplasia to discuss the prognosis and management of the condition. And here are the main points. I think you can read this, but we already discussed this. Are there any discussion?
And in particular here, sorry, it's Martin again. If anyone has any wording they think should be changed, if they have a word to change, we can have that discussion as well. Or is it absolutely clear to you? And to Chris's point about English, we've tried to make it general, but again, at this stage, you can suggest any changes to the principle.
So from my side, I'm not a good English-speaking person. I think I can understand it. I agree with wording.
Yeah, can I just raise one comment just about wording? You know, words can be very, very strong sometimes. So the word that jumps out to me is immediately. And one of the things that sometimes colleagues get worried about is if a recommendation tells them to do something that then they don't, they worry about the medical legal consequence of that. Now, I'm not sure we should spend too much time worrying about this. This is a recommendation from a specialist group of experts rather than an official body. But sometimes having absolutely strong words like immediately and must be are too strong, and we might say should or may or could. You know, these words mean different degrees. That's my only comment. Just immediately is a very strong word.
From my perspective, immediately is fine, because everybody knows of us these cases where the mother gets the information about there's something wrong with your child. Go to your home doctor, and the home doctor has no real experience in this, and so everything is it's not quite good, and that's why we were thinking really, like in rheumatology, you can say maybe you give pain drugs or something like this, but in this case we really want to counsel this family in the right way. So that's why immediately I would say this is important. Yeah, but I don't know what the other people.
I mean, I agree with Edward's comment. This family need to be referred, should immediately be referred. That's something different. And this is very strong statement about should immediately be referred. It's quite an order.
Yeah, we can live immediately, I think.
But can I just have a show of hands then, just on the screen? Should we take out the word immediately?
Yes.
Yes.
Who says yes?
Me, Christian.
I will temper should as well.
Second? So Christian said yes, and I saw Melita say yes.
Yes.
Mary says yes. Okay, so let's. I guess Kate, this is going to be you, just to. It's one of those times, I think, Chris, as you say, it doesn't change it dramatically, but if it causes problems, I think that's.
Yeah, to me, should is quite a strong word in recommendations. That's saying that's what we should all be doing.
What I wanted to say is, it could mean to some people that once you have you have received the diagnosis, the possible diagnosis, that your child is suffering from achondroplasia, the next place you have to go is to the specialist. And this is, I think, this is too strong for the.
Could be need to be.
Sergio?
Can I speak up? I agree with Klaus, at least here for our reality. A referral sometimes can take months. And if it just been left like that, it doesn't mean like it would be okay that in 6 months it goes to the specialist. But actually they need to be seen in very short time.
Should be referred as soon as possible, maybe, to a physician.
Okay.
Or something like that should in a short.
Do we like that? Okay. Klaus, you happy to go to a vote?
Yeah, I think we can vote now.
Callum? Gert, are you seeing this one yet?
Gert makes in an old-fashioned way. Yeah.
I've never had the polling fail with one person in the group before. That's very, very weird. It's I'm interested to know why.
Not working for Silvio either, I don't think.
Okay, Callum, the votes in.
We have 9 votes so far.
So that 9 plus Gert?
Yes, 10.
10. Some people have not voted.
But it's like Silvio's gone.
Okay.
And he wasn't able to vote either, by the way. He was putting his votes in the chat.
Yeah.
Silvio is gone. Yeah.
Okay, let's.
Yeah, now 11.
I will leave and try to log in again to really make it possible for me. So I'll just leave and go in a minute. Okay.
Okay.
Sorry, Gert.
So we will. We'll wait for Gert to come back. Let's look at the results so far, then, Callum.
Oh. 100% now.
Well, that shows the benefit of just tweaking the wording. I think that's great. But wow, 100%. That's good. Okay, so let's.
Can I make a comment on the still? I mean, whether the experience in achondroplasia to discuss the management and the prognosis, because if you have an early foramen magnum stenosis in the first months of life, then you discuss the management and then the prognosis. That's my feeling.
So okay. What you recommend that we can include?
No, just revert to discuss the management and the prognosis.
Yeah, just change the 2 words around. That's
the only thing I would say about the principle of this, and it's not my meeting, so I don't want to be forceful about this, is if you voted on something and it's been carried by 100%, you shouldn't change it afterwards. Or if you change it, you've got to vote again. But if you vote and it's carried, then it just makes the process more difficult, doesn't it? But not my meeting.
I agree.
And also, I think to discuss the prognosis is always the first step, and then during the same session we talk about the management. Yeah.
Okay, so Callum, let's pull up the Gert is back, so hopefully you can see it this time. So can you see that pop up now, Gert?
Oh no, I see it. Okay.
Hey.
No, it works. So where are we left now? Because
So we had 100% agreement on the principle. So now, and how strongly do you agree with this principle?
So I should vote right now?
Yep. Everyone can vote, then click vote and then submit.
Yeah, 12 votes.
Perfect. Okay, let's move on to the next principle then.
Get we the results before?
We can do. I wasn't going to share the results of the strength of opinion because it just causes other discussion, but we can show it if it's up to you guys. Do you want to see the results?
Yes.
Yes.
Okay,
Yes,
let's Callum share the results.
Okay.
Okay, thank you.
8, 9, 10. So
Okay, thank you. The next statement is decision making should be shared between the person with achondroplasia or their family and the multidisciplinary team. So there are some comments on this and aspects. Who will discuss?
Professor Clark, just quick question. Are we just looking at the main sentence or we also should look at all the points?
Yeah, I would say we should look all the points. That's why I started in the first step, but
Okay.
as a matter of time, because otherwise maybe we misunderstand what this means.
Okay.
The comment I have with this statement that this is to me a bit vague. I mean, this to me is true for like every condition, right? I mean, it's not so specific for achondroplasia that decision making should be made between the person affected and the family and the team involved.
Mm-hmm. You're right.
Yeah. What's the sentiment around this principle?
This was last time when the first meeting, it was, I think, that in earlier times, people, the patient were not part of the decision team, and now we are in the modern world where we really go step by step. With the diagnostic process and therapy. So this was my understanding of the statement.
I agree with Gert. This is true for every rare disease and for every disease we are going to manage. So I completely agree. This is not specific for achondroplasia.
Correct. Yeah.
But
I agree. Yeah.
It is a high level principle that we would practice.
I think to me the key point here is the multidisciplinary team, because I think it may be well developed in certain places, but in other places it's only maybe one main physician that is seeing and following the patient with achondroplasia, and maybe with some other rare diseases as well. So I think to me, what's really important is to have a multidisciplinary team explaining and then making a shared decision with the family. So if you're talking about growth hormone, it would be nice to have a pediatric endocrinologist, for example. If you are talking about some surgical procedures, then you would like to have an orthopedic surgeon in the meeting. In certain places, it's the primary physician who is shouldering all that on his or her responsibility. So I think that's the key point here. I think we all agree that everything should be shared with the person or with any disease, but the multidisciplinary team is really very important.
This is Martin. Just to, as we got all your input and crafted, I think those were the 2 points which came out. I think because it's common to everything doesn't mean it shouldn't be included. And I think because it comes out in most of the rheumatology recommendations somewhere as a sharing responsibility. But I think also there were times when perhaps decisions were made away from perhaps even a centre. You know, surgical decisions made separate to clinical decisions, and I think that was one of the observations that came across, that sometimes things are fragmented, and so it was the whole team approach making a decision. I think was the reason we added that, not just between the patient and the clinician, but between the team and the patient and the family.
I was just also thinking about, we've had similar discussions for the rheumatology guidelines, that these can seem like very, very obvious things, but I think this sort of comment is also a statement of intent to patient groups and to patients, that we value them and they're important. And although that's obvious to us, and if we work in good centres, we would always include people, but I think that statement of intent can be important to be visible to patient groups and to families.
What about making more emphasis on the multidisciplinary aspect? For example, saying or rephrasing it as follows: the involvement of a multidisciplinary team should be encouraged in the decision-making aspects of care in persons with achondroplasia. I mean, putting this a bit more in front, or putting more focus or more emphasis on the involvement of the multidisciplinary team and the importance in decision making. Maybe that's something we could consider.
And even maybe putting that the multidisciplinary team should be in close contact with the patient associations.
Yeah, but with the patient organization in some countries, there is not such an effective patient organization than in others. Yeah. So
I think we've introduced the multidisciplinary team in the previous recommendation. We've already, or guiding principle, I guess, where we say we should refer to a multidisciplinary team. So if that makes any difference, we have sort of covered that to an extent.
I think that we have to emphasize an MDT, because some late referrer, at least in my experience, are related to the fact that the physician sometimes is alone to take the decision. So this is just to emphasize that you need to talk with somebody else who have some additional experience. And I think that is, it looks like to be obvious, but in the real world, many late referral are still in our experience.
I think MDT is very important for this decision making. For example, if you talk about anesthesia or so, you can combine anesthesia for different diagnostics also. So and I think for the statement is, yeah, we should leave it. Yeah, I don't know.
Yes, I think that the statement, the first part, is related to the basic bioethical principle of autonomy in patient and family. So the real point, I agree, is MDT. So maybe we have to transform this sentence in something different to vote.
Do we have a proposal for the sentence? It's difficult for me. I'm just trying to think if there's an alternate wording.
No, it means decision making should be made by MDT together with the family or so. I'm not sure if you are agree, but in our situation we really discuss it and ask the family if they agree with these or these, because they are sometimes from our physician's perspective very different to the family's perspective. Yeah.
I think that the person is in the first place always, respecting the autonomy principle.
Yeah.
So maybe it would be better to say something like, in the decision-making process of the person with achondroplasia or the family, the MDT opinion or perspective will be very important.
So I think what we're trying, the principle that we're trying to prove is that there should be a multidisciplinary team involved, and the person with achondroplasia or their family should also be involved. That's what we're trying to achieve here, is it, with the sentence?
Yeah.
Yeah. Okay.
Will be involved. Yeah.
No, the MDT will give the options. So at the moment, now it looks like that's the person.
I got it. Yeah. So decisions. Hang on, I've just got to say what's on my mind. Decisions around management should be made in a multidisciplinary team setting in conjunction with the family.
Yeah.
Sounds okay.
Can you repeat that, please? Decisions around management.
Decisions around management should be made in the multidisciplinary team setting in conjunction with the family stroke person with achondroplasia.
In conjunction.
Is conjunction an easily translated word, just for everybody?
Yeah.
Yep.
Yeah, so this is an example for what you said before, Chris, yeah?
Should be made in the MDT setting. It could just be, you could get rid of in conjunction, couldn't you?
Well, the whole sentiment is that it's a joint decision.
Okay.
So how about jointly?
Jointly, yeah.
Or partnership. Perfect.
It might be a bit woolly. Like they're in the room when we made the decision.
Yeah. I think they always end up a bit woolly, don't they? But I think that's the sentiment, isn't it? You know, if I was looking at that from the outside, this says MDT. It said the patient and their family are important. I think that looks great.
Okay, let's vote.
Well, let's go for a vote.
Yeah.
Don't anybody say no.
How now?
Yeah, that's why we had anonymous voting for that sort of pressure. That's why we love democracy.
Callum, how are the numbers?
11 now.
Everybody's in then. Let's have a...
Oh, 100%.
Anita, the wordsmith, is perfect. That's, how strongly do you agree with this principle?
Okay, I've got 12, so I'll share the results now.
Great.
Very strong agreement.
Yeah.
Okay, Kate, I'm conscious of time, but we're going through this at great pace, so that's it's terrific. But if there's things we can't get to agreement on, obviously we can communicate over email, etc. So, next one, Kate.
The primary goals of management are to enable early identification and treatment of emergent problems, provide education, support to encourage a healthy lifestyle, positive self-esteem and mental health, and to encourage independence.
Yeah.
I like this too.
It's a nice comprehensive statement.
Yes.
Encourage is repeated twice. I wonder whether we can, and self-autonomy.
Sorry, Mohammed, say that again.
I mean, self-esteem and mental health and self-autonomy, because encourage is repeated twice in the 3 lines.
Encourage, yeah.
Okay.
And self-autonomy could be.
So to finish with and.
Yes. Self-esteem, mental health.
And autonomy, not self-autonomy.
Yes, right.
Yeah. Autonomy, yeah.
And independence, maybe.
We just swapped that out for autonomy.
It's a difference
removing
between
courage, just independence.
So you can take out the and put a comma for sorry.
What about an independent life? Oh no.
Independent, yeah. Independence, that's fine.
Okay.
Is this a difference, independence and autonomy?
Yes, it's not. It's almost the same, no?
No, I think there's independent living, isn't there? Like being able to do stuff by yourself.
And autonomy is the same, no?
And well, autonomy is making decisions for yourself.
No?
Do you think it helps by
Autonomy
having?
is more towards decision making, and independence is more general. I think, you know, independence in every aspect, and living alone and depending on oneself, in addition to have. I think
But this is autonomy
broader.
too. If I'm living autonomous, I'm independent too, or
Yes.
I never will be independent because I dependent on the supermarket and so on. Yeah, but
when you're in the supermarket, it's your autonomous decision to choose Heinz over Tesco's bacon. Yeah.
So
autonomy is around decision making.
Okay, so for
doing stuff by yourself.
It's a minor thing, I think.
Okay.
Is it only the emergent problems we should manage, or
no?
There could be also a thing that could be anticipated, but we just monitor it. It's not only the emergent problems, I think, but all kind of complications that might occur, as we know, with achondroplasia. So, could we replace emergent with a better
daily
word?
life? Daily life? Daily life? No.
Melita, can you help us? It's all the stuff you have in your table.
If they've got long-standing spinal stenosis, this statement says, "Forget about it. It's not a priority for us." That's what you're saying, isn't it?
You could just remove emergent, couldn't you?
Yeah, that would do it.
But I think we should.
I think anticipatory is a good word. Because we can add R to enable early, anticipatory identification and treatment. Would that?
So do we need the word? I know early is important, but if we just read the primary goals of management are to enable anticipation, identification, and treatment of problems.
Yeah, beautiful.
I think the point is that it's just what you said, Melita, about the foramen magnum stenosis. They don't have any symptoms, but you do the MRI because you know there could be a problem. So that's what I meant. It's not emergent because they have no symptoms, but you know that you should do the MRI as well.
Right.
Yeah, that's brilliant.
That reads very nicely.
It's amazing what a difference changing one or two words can do. So Sven, that's critical to add that in. I think that's really important.
Less is more.
Yeah, there's quite a lot on this one. Okay, well let's try a vote and see how we go. There we go. So we all agree. And how strongly do we agree? Well, I say we all agree. I don't agree, but I mean, I don't vote, but it's
That's 10 votes so far.
Anybody else to vote?
That's 11. And that's the 12.
It's like 12 angry men, isn't it?
Oh.
It's good. We're in the averaging 90%. That's very strong. So I think it's great. Okay, Klaus, back to you again. Sorry, next word.
So patients should have access to a variety of adaptive measures, support to ensure proper usage, and priority access the new medications as they become available. I think this is an interesting statement. What is the opinion, the comment?
Well,
kind of covers a multitude of sins, doesn't it?
It's a mix of different things. Yes, it's difficult to follow. It's quite important, but there are really distinct things.
What were you going to say, Christian?
I wanted to say that if there are new medications for achondroplasia on the horizon, why should they need priority? Because they are made for them. Who else should use them? This is, you see, that doesn't make real sense to me.
Yeah, and priority access always makes me think of being in Disneyland or something like that.
Yeah, yeah.
It doesn't sound right, like the right phrase for something as serious as a drug.
I agree with that. It triggers politicians.
So if we move priority, is that better?
I would say yes. Yeah.
So this is
maybe
like saying you should have adaptations to in your life and new medications. Adaptations in your life, making sure you can use them properly, and medications, which is a bit of a
adaptive measure means a certain stool or a chair or something like this. Yeah.
The sentiment here is like you should have access to things that make your life more manageable.
Yeah.
Whether that be things that make things better for you, whether that be home adaptations or medications.
Yeah, for example, we discussed very often with the patient organization what is, for example, to go into the shower. It's better to have a new bathroom for your family also. And these kind of adaptive measures are paid then by social security agencies also, and so in this kind. But I think in other countries it's not the case that they get money for changing the bathroom also. So but I think this is fine to say have access to a variety of adaptive measures. So I think in this way I would say it's okay, but I don't know what other people think.
So I think, Klaus, what we're trying to say is that this is two different things. It's like, yes, all of those measures that people need on a day-to-day basis to help them access their environment, but then medications as well in the same principle is a bit a bit innocuous with the two different things.
If it's Martin, I'll just come in again. So I think, Melita, you're right, obviously. Again, trying to get to the principle of keeping the number of principles low. That was a start. So we had a number of things that came in talking about, and certainly in our discussions, in certain countries they have much less access to some of those simple adaptive measures and home changes which can make your life more independent and more adaptable. So there was certainly some sentiment around that, as well as whether it's occupational therapy or other things to make certain that you can use those adaptive measures, because sometimes people could just order them and don't get them. Yeah. And then there was another comment around there aren't many medications, and the reason priority was in there, and I accept it, it was more about sometimes these medicines take a long time to become available in the country. Reimbursement takes years and years and years, and it's trying to put a sense of urgency, and there's a difference between perhaps Germany, France, the UK, and how long new medicines take, and so that came in from somebody that's when they get these medicines, let's not wait for years to get them. And I think that's why we tried to lump them together, and it's obviously your guys' decision, but that was the genesis of not wanting 12 different guiding principles. So this is more about giving patients we've got all these investigations and giving them the medicines and the tools in order to achieve those goals. That was the reason we brought it together, but again, it's up to you guys to change it as you see fit.
I was wondering if we should specify to medications and not make it more general, like treatments. I'm thinking of new developments in surgery that are not reimbursed, and so that would also be important to be included, that patients also have access to these, not just medical treatment, but also surgical treatment.
So in England, we'd probably use the word technologies. Would that be a word that would be used elsewhere?
Treatment options, could that be used?
Yeah.
And also maybe put...
Maybe I would add effective treatment options.
Perhaps what issues are there available?
No, I wouldn't say effective, because then, for example, insurance will always have this proof. And I think whenever a treatment is in one way effective, for example, if you take vosoritide, it would be in young children very effective, but in older children not. Also, I think access to new treatment options is the right wording.
I think for me that makes a big difference. It makes sense because it covers some of the stuff you discussed. You know, like surgery, like as you develop these other areas. I think certainly that seems very interesting. It could be a new way of diagnosing earlier, I guess, things like that. So that makes sense. I think, again, it's not for me to have an opinion, but
it depends on the setting, because we can have the other phase. I mean, in public setting, the patient could demand, or the family, certain option of treatment that they are not effective, and then, you know, and put it in a problem because you consider that it's not appropriate for the care of the child, of the adult with achondroplasia, for example. We have many problems with that because the system is universal, and when something is approved maybe for other indication, and you say, I need that treatment because, you know, anything. So there are two phases.
We're not approved treatment, because in the case of drugs we have an agency, and in other cases
yes, that would
not new, approved.
It doesn't need to be new. That's right.
Maybe should we put at least a sentence from the ones below on therapies, physiotherapy, occupational therapy, because and not only thinking on medication, I think.
Yeah, that's important. Very important.
Physiotherapy, and what was the other one you said? I'm sorry, I missed
surgery.
And occupational therapy, I think, was also mentioned.
Yeah.
Occupational. Yeah.
And again, we'll add these in the manuscript. I'm conscious of time, so let's have a go at voting on this one and see where we are.
We have 11 votes in so far.
Okay, let's close it there then. Okay.
Oh, 91%.
So we have a good agreement. Okay, we've got a couple more to get through, so we'll try. Again, if we don't get time today, we can certainly revisit. So please don't feel pushed. But how strongly do you agree with this statement?
And that's 11.
Somebody dropped out. We're getting 12 before, but
I'm doing it, so don't blame me.
Okay, let's. Okay. One slightly lower. That's good. Good to get some challenge. And I think, just to repeat, I think something that Chris said earlier. You know, I think the EULAR recommendations are on about their 5th iteration now, aren't they, Chris? And they get wordsmith as they go along. So I think it's good to see how we evolve it as we go forward.
Yeah, and where there's more difference, it also allows you to identify where there's a difference of opinion, where there's a research agenda. So actually seeing the difference is a good thing.
Okay, the next.
Nice to hear from. Excuse me. It'd be nice to hear from the lowest, scores. I mean, what's the opinion, so we can learn from it. I mean, I saw some 5, I saw some 6, I saw some disagree with the recommendation.
We need to be anonymous, though, don't we? Otherwise, people.
We need
only.
okay.
My only worry. I mean, it's up to you. It's not your meeting. But my only worry would be if it stops being anonymous, people tend to vote with the group.
Oh, I don't know. I mean, I thought this is quite an open forum. We can disagree, and there's no hard feeling because generally, as I said, the evidence is all sketchy around achondroplasia anyhow. So, I mean,
but maybe when we have these manuscripts, we can discuss again, and then people will comment on this, I think, yeah?
Yeah.
Okay, the next statement is regular monitoring in adolescence and adulthood should continue under multidisciplinary team and lead physician with expertise in achondroplasia management. Care should include genetic counseling and management of pregnancy. Are there any comments?
Well, the comment I would have here is, what is the lead physician with expertise in achondroplasia management? I mean, I guess the neurosurgeon will say, well, that's me. And the orthopedic surgeon will say, well, that's me. And the ENT person will say, well, that's me. So who is the lead physician here? So can we not just delete this?
Continue under an MDT and nothing else.
Yeah.
Couple of comments. Well, I wonder if we can add sexuality also. Not just care should include genetic counseling, sexuality, and management of pregnancy, because that's where the adolescence, puberty issues, and in males, also it's not only males with pregnancies. Also, I think the lead physician is important because even in a given multidisciplinary team, there's always a leading person who's responsible for coordinating the care. So I think it should be there or it should be in the points below. We could add somewhere there that a multidisciplinary team with a lead coordinator maybe, or something like that, because I think without a primary coordinator, it just doesn't work in a multidisciplinary team.
Yeah, that's correct.
And it's often a pediatrician, it's often a geneticist, it's often sometimes an experienced nurse, sometimes a genetic counselor. It's different from one, I guess, institute to the other.
I'm not sure whether this will be a separate point or statement, but I think also because this statement includes both adolescents and adults, I think there's a very important time for transition from childhood into adulthood, which I think is especially difficult for individuals with achondroplasia, because then the difference compared to their peers is become even more obvious. So maybe it's to putting the goal very high, of course, but I think we might consider putting transition as well as sexuality, because I think that's sexuality is one thing, but it will cover like becoming independent, education, working, that kind of challenges, which I think is important to discuss at that point.
So you would remove sexuality and transition? No.
I think sexuality is something different. I think sexuality can remain, but I think maybe transition is something else. And I mean, all teenagers are struggling with this, but I think individuals with achondroplasia have even more hard times with this with the transition.
Would you suggest transition to adulthood, or is just transition okay?
Let me see. Oh, okay.
Transition to adulthood sounds good to me, because it prevents people thinking about different sorts of transition.
Yeah,
I agree.
And I also wondered, just in the wording, whether sexual health, in its broader sense, rather than sexuality, which to me it means a slightly different thing.
I think that's what he means, though.
Oh, all of it.
Yeah.
Okay.
No, I'm fine with sexual health.
I assume a pregnancy also include delivery.
Yeah.
I mean, I assume too that pregnancy include potential pregnancy before.
Yes.
Yes.
I don't know if it is important to also to emphasize the prevention of obesity, because it's a real problem in achondroplasia.
Prevention of what did you say?
Obesity.
Obesity.
Yeah. Obesity is below. Yeah. I think one important point.
Oh yes, I see that. Yeah. I see that.
One important point is
I had yesterday the clinic, and after this COVID-19 period, children are more obese.
Yeah. I think the main point for this statement was that in adults, maybe between 20 to 40 and later, they are only treated by orthopedics and not a multidisciplinary team anymore. And we say this might be better with a multidisciplinary team, and not only because, for example, the orthopedic will tell you obese is very bad, but they will not give you real advice how to go with obesity. That's
maybe
why.
we can also involve the rheumatologist because they take care of these patients very often in our experience, even more than orthopedic surgeon, because we work only when they need a surgery, but in the other case, our rheumatologist team they take care of them. So maybe lead coordinator, maybe in adult achondroplasia patient can be a rheumatologist.
Rheumatology, yeah, okay. I think this is very different in European countries. So I think in your case it would be rheumatologist, and in other case
for adult patients only. We are speaking about adult patients only.
Yes.
Yeah.
I really like the addition of rheumatology. Thank you. Merci.
Please explain.
My time here has been worthwhile. I've infiltrated.
I'm not sure that all adult rheumatologists would be happy about that, Edward.
And back to sexuality, I've thought of a phrase that encompasses everything, which is psychosexual well-being.
Psychosexual. Now you're testing my spelling.
Psycho as in psychology.
Psychosexual
well-being. Maureen, does that tick the box?
Yeah, it's fine with me.
Happy. Maureen's happy.
Does that translate okay?
I mean, I would say psychology and sexual well-being separately. Because I think that, but it's fine. I mean, it's just playing with words, I suppose.
Hey, let's go for it. Let's see how we're doing on this one. And this is number 6. This is the last one. So we've done a great job if we agree. Or we can keep on. We can go back and do some more. But there we go. So let's.
But in 5 years, we have to repeat.
probably 3 years. Okay, let's take the agreement. Hopefully, Melita, this was shorter than your recommendations paper.
Good. 100%.
Okay, that's
great.
Sorry, I'll come off on our camera. Klaus, back to you.
Mm-hmm. Yeah, I think I'm almost done with your help. Yeah, I think this would be other principles. There are a lot of other principles, but we can add this when the manuscript is circulated, and it might be possible then. Or is a very urgent adding?
No, I think if no one's got anything burning they think we've missed, then I think it's key to move on. I think it was just that question of, have we missed anything totally that you think we haven't done? And that sounds like a no. So, as you said, the manuscript will flesh it out, but that's great.
I wonder whether the psychological issues, the quality of life, the daily, what about their job or these aspects that may impact their quality of life and well-being.
Yeah, I exactly what Dr. Muhammad is saying. I was just going to put this word quality of life. I wonder if that could go as a separate entity. I'm not sure.
Yeah, but what we can recommend in this way, I think
that we can address autonomy, self-autonomy based on age and expectations. All these in terms of quality of life.
Mm-hmm.
I think we need to reassure these patients in some way.
Yeah. What about to give this draft then to a patient group also?
Klaus, maybe I add one of the things I've seen in some of my patients with achondroplasia that may not be highlighted that much is pain. And I think, that is a very important measure of quality of life.
Yeah.
So I think maybe now or later, if we can think of adding that somewhere in our manuscript, that would be important.
I agree with Al-Said, because if you look at the abstract by BioMarine about quality of life questionnaires, that's really terrific. So I think that a lot of aspects should be taken into consideration from that abstract.
Mm-hmm. Okay.
I agree about the pain too.
Yeah, the pain is a very important point, which is also medical. Mm-hmm. Okay. I think we will give it to the manuscript, this last sentence, and yeah, thank you very much for your very lively discussion. Thank you.